Welcome to the Deep Dive, our mission. We take these complex sources, stacks of them sometimes, and, well, we give you the shortcut to understanding the core ideas. And today, we are diving deep into something incredibly pressing, ethically complex. How do we, as a society, justly divide up healthcare resources? Because, let's face it, they're limited. We're really looking at justice on a huge scale here, societal policy, not so much the person-to-person moral stuff. The sources frame it right away. What's a fair distribution? What are the less fortunate actually entitled to? What do we owe them when it comes to health?
Exactly. And that question is just amplified by this harsh reality. Resources are finite. Costs are, well, they're skyrocketing. And healthcare has to fight for funding against everything else. Defense, education, roads. We just can't provide everything for everyone. So our goal today is to pull out the key moral principles, the different theories of justice clashing here, and the specific arguments about rationing that come up. Basically, give you a framework to understand these debates.
Okay, so let's start with the landscape. Where are we now, particularly in the U.S.? Because it's kind of a paradox, isn't it? We're this incredibly wealthy nation. Yet the sources highlight significant problems with access. Like in 2019, nearly 29 million Americans under 65 didn't have insurance. And the main reason...
Just too expensive.
And that lack of insurance, it has a real measurable human cost. The uninsured are estimated to be about 25% more likely to die prematurely than people with insurance.
Wow.
Yeah, one estimate figured that translated to about 18,000 extra deaths just in the year 2000 among working-age adults. It really forces you to see that our allocation system was failing a lot of people.
Okay, if we were spending less and getting those kinds of results, that might be understandable, maybe, but that's not the story, is it?
Not at all. That's where it gets really staggering, ethically speaking. The U.S. is a huge outlier globally. We spend vastly more than any comparable wealthy OECD country.
How much more are we talking?
Over $10,000 per person per year. Way more than, say, Switzerland or the U.K., thousands more.
And yet, the outcomes, despite pouring all that money in, our overall health outcomes are often mediocre, sometimes worse. Lower life expectancy compared to many, higher infant mortality, about 5.9 deaths per 1,000 live births, which is higher than almost every other developed nation.
But we do well in some areas, right?
We do. The sources mention things like better 30-day survival rates after heart attacks or strokes and for some specific cancers. But when you look at the big picture access, overall health outcomes that basic care should improve, we lag behind significantly.
So this massive spending leading to potentially 18,000 avoidable deaths a year, it really shows that this whole debate isn't just about money, is it? It's rooted in really deep disagreements about what justice even means.
Absolutely. And that's our cue to get into the core theories of distributive justice. How should society's benefits and burdens be shared?
Right. Philosophers usually talk about three main camps here.
Pretty much. First, you've got the libertarian theories. For libertarians, justice is all about individual liberty, your rights, especially property rights, and letting the free market work. The government's job is really just to protect those rights.
Okay, so if the government protects my right to my property and my freedom to make deals,
then it has no business, they'd argue, taking your resources, like through taxes, to give benefits like health care to someone else. There's no right to health care in this view.
And forcing people to pay for it is unjust.
Unjust coercion, exactly. The state isn't supposed to be a charity. It's a rights protector. Now, at the other end of the spectrum, you have egalitarian theories.
Egalitarian sounds like equality.
Precisely. Egalitarians believe benefits and burdens should be distributed equally. If there's significant inequality, they see that as inherently unjust, and they believe the government has a moral duty, maybe even a coercive one, to step in and fix it.
So that could mean things like universal health care or maybe a guaranteed basic level of care for everyone.
Could be. Or even policies that prioritize the worst off. The key is reducing inequality to achieve fairness. Then, sort of in the middle, you find utilitarian theory.
Utilitarianism, that's about maximizing happiness, right? Or overall good.
Exactly. For a utilitarian, justice is simply whatever arrangement produces the greatest net good, the most utility for society as a whole. An allocation, like for healthcare, is just if it results in the best overall consequences.
That sounds flexible.
It is. A utilitarian might back universal care if the evidence shows it leads to, say, a healthier, more productive workforce and greater social stability, maximizing overall good.
Or they might argue a two-tiered system does that better, maybe by fostering innovation or something.
Potentially. It all comes down to the calculation. Which policy actually produces the most benefit for the most people? It's strictly about the outcomes.
And there was one more approach mentioned.
Right, the human rights approach. This perspective sees health and human rights as deeply connected. It argues that if you protect basic human rights, things like freedom from discrimination, access to information, you inherently promote health, and access to care.
Okay, so these theories give us different ways to think about fairness, but let's circle back to that idea of a right to health care. When people argue for that, what kind of right are they usually talking about?
Good question. They're usually arguing for a positive right. That means society, or the government, has a positive duty to actually provide something, in this case, healthcare.
As opposed to a negative right, which is just the duty not to interfere, like freedom of speech, the government just has to leave you alone.
Exactly. A positive right requires action, provision. And the big philosophical question is, why does society have this positive duty to provide healthcare?
And Norman Daniels has a famous argument for this.
He does. Daniels connects it to John Rawls's very influential idea of fair equality of opportunity. Rawls argued that a just society has to ensure everyone has a fair chance to pursue the basic goods in life.
Okay, so how does health fit in?
Well, Daniels says that disease and disability impair what he calls normal species functioning. Basically, being sick or disabled limits your opportunities, your ability to function normally in society and pursue your goals.
Right, it restricts your range of possibilities.
Precisely. So, if society is committed to fair equality of opportunity, Daniels argues, then it must provide adequate health care needed to protect and restore that normal functioning, that range of opportunity. It's not just a nice thing to have, it's required for justice.
That's a strong argument, but it often leads to this sort of compromise idea, doesn't it? The decent minimum.
Yeah, that's a common outcome. The idea is, okay, maybe we can't guarantee everything for everyone, but society should guarantee a basic, decent level of care for all citizens. You might still have a private tier above that for those who can afford it.
But then the huge question becomes, what counts as decent? Is it just routine checkups and basic treatments?
Or does it include really expensive things, like heart transplants? What about lifelong care for severe mental impairments? Cosmetic surgery is probably out, but where do you draw the line?
It's incredibly tricky because every service added to that minimum costs money that could go elsewhere.
And Allen Buchanan offers a different take. He actually argues against a universal right to a decent minimum, but interestingly, he still concludes that society has a duty to provide it. His reasoning is pluralistic. It comes from several angles.
So if it's not a universal right, what justifies this duty for Buchanan?
He points to a few things, like special rights, maybe rights owed to specific groups due to past injustices like Native Americans, or compensation for harm caused by corporations, or care for wounded veterans. But his most general argument, I think, is based on enforced beneficence.
Enforced beneficence sounds like mandatory charity.
Kind of.
Yeah.
Buchanan looks at healthcare charity as a public good, meaning everyone benefits when the population is generally healthy, fewer epidemics, more productive workforce, etc.
Okay, I get that.
But with public goods, there's a free rider problem. Individuals might think, my small donation won't make a difference, or others will donate, so I don't need to. So voluntary charity alone might not be enough to achieve the desired outcome.
So the government steps in.
Buchanan argues that coercive government action, like using taxes to fund healthcare, is justified here, not because of a right to care, but to ensure this collective beneficial act of charity actually happens. It's enforcing our moral duty to help each other when we wouldn't coordinate effectively on our own.
That's a really interesting distinction. Okay, so that covers the big picture, the macro level system. But what about when resources are scarce right now? Like, not enough organs for everyone who needs one. That brings us to microallocation, right? Rationing.
Exactly. And this is where the ethical questions become incredibly immediate, often agonizing. Who gets the transplant? Who gets the ICU bed? Sometimes it really does feel like deciding who lives and who dies.
And the utilitarian approach has a specific tool for this, doesn't it? The QALY.
It does. The QLA, or Quality Adjusted Life Year, it's a controversial metric, but the idea is simple. 1 QLAY equals 1 year of life lived in perfect health. Years lived in poorer health count as fractions of a QAY.
So when you're rationing, you pick the option that gives the most QALYs.
That's the utilitarian logic.
Yeah.
Maximize the total health benefit. So take your example. 2 hearts available. 2 younger patients might each gain 10 QALYs from a transplant. 1 older patient might only gain 5 QALYs. The QALY approach says give the heart to the younger patients, you get 20 total QALYs versus just 5. maximize the good.
But that feels uncomfortable.
It is. And philosopher John Harris launched a really powerful critique against QALYs. He argues they're fundamentally unfair.
How so? What's the main problem?
Well, two big ones. First, Harris points out an inherent ageist bias. Because younger people simply have more potential years left to live, the QALY calculation will almost always favor them over older people, regardless of anything else.
Just based on age alone.
Right. Second, he argues it discriminates against people with disabilities. Imagine a paraplegic who deeply values their life. They might need a treatment, but because their baseline health isn't perfect, their potential QALY gain will be calculated as lower than a healthy person needing the same treatment.
So the metric overrides the person's own view of their life's value.
Exactly. Harris argues that substituting this objective, impersonal measurement for a person's subjective valuation of their own life is morally wrong. It fails to respect individual worth.
And this kind of tension between cold calculations or rules and, the patient right in front of you, that plays out in managed care systems too, right? The source mentioned the Christine Demur's case file.
Yes, that's a really potent example. Christine was a young mother. She had metastatic breast cancer. Her oncologist, Dr. Glaspie, believed an experimental bone marrow transplant was her best shot.
But her HMO, HealthNet, refused to cover it.
They denied it, calling it investigational, citing a clause in her policy. Dr. Glaspie felt trapped. His duty was to Christine, but he was also part of this cost-conscious organization.
It put him in an impossible position.
Completely. Christine had to fight, find outside funding, go to a different hospital willing to help. Sadly, she did pass away later, but an arbitration panel eventually ruled that HealthNet had acted improperly, interfering with the doctor-patient relationship.
It just vividly shows how the systems we use for allocation, HMOs, PPOs, what we call managed care, create these deep ethical conflicts between cost control and actually caring for the patient. It can really damage trust.
Absolutely. Now, shifting gears to the very broadest level, we need to touch on public health ethics. This is like bioethics, but focused on entire populations, aiming to maximize health and prevent harm across the community.
And this often involves the state needing to limit individual freedoms, right? Things like mandatory quarantines or vaccination.
Exactly. Public health constantly bumps up against individual liberty. So the ethical challenge is, when is it okay for the state to interfere with your autonomy or privacy for the sake of the community's health?
There must be some criteria for justifying that.
There are. The sources lay out 5 key justificatory conditions that need to be met for an intervention that infringes on liberty or privacy to be considered ethical. First, effectiveness. The policy has to actually be likely to work to protect public health.
Makes sense. You can't restrict freedom for something pointless.
Second, proportionality. The benefits of the policy, the health gains, must outweigh the moral costs, the infringement on liberty or privacy. If you gain very little but restrict a lot, it's disproportionate.
Okay, what else?
Third, necessity. Is this infringement absolutely required? Have less restrictive options like education campaigns, incentives been tried or ruled out. You have to use the least morally troubling alternative that will still be effective.
The least restrictive path.
Right. Fourth, relatedly, is least infringement. Even when an infringement is necessary, you have to design the policy to minimize the violation as much as possible.
And the last one?
Public justification. Crucially, the reasons for the infringement must be explained clearly and transparently to the public. You need to maintain trust, especially when using coercive measures.
This all seems to lead to that classic conflict over paternalism, doesn't it? The state telling you what's good for you.
It does. Public health interventions often are paternalistic. The real ethical sticking point is usually with strong paternalism, sometimes called hard paternalism. That's when the state interferes with your voluntary, informed, self-regarding actions purely for your own benefit.
Like forcing me to wear a motorcycle helmet, even if I understand the risks and choose not to, that feels like a violation of my autonomy if I'm only potentially harming myself.
That's the heart of the debate. Public health officials often try to argue such actions aren't purely self-regarding. They'll say, well, if you get a head injury, society bears the costs through emergency services, insurance pools, lost productivity.
So they try to reframe it as harming others indirectly.
Exactly. They try to make it other regarding to justify the intervention on non-paternalistic grounds, like harm prevention to the community budget. But you have to be really careful with that kind of argument. Is it a genuine justification, or is it just a way to override individual choice because we think we know better? It's a very fine line to walk without disrespecting autonomy.
Wow. Okay, we've covered a huge amount of ground here, from the failures in the U.S. system through these big theories of justice down to QALYs and individual patient cases and up to public health policy. What are the key takeaways for you?
Well, I think first, recognizing the U.S. healthcare situation is unique massive spending, yet often poor outcomes compared to peers. That's crucial context. Second, understanding that justice in healthcare isn't simple. It involves navigating these deep conflicts between libertarian ideas of freedom, utilitarian calculations of benefit, and egalitarian demands for equality. Third, realizing that microallocation choices like rationing organs using metrics like QALYs are ethically perilous. They force us to confront whether we value utility over individual worth, and we have to be aware of hidden biases. And finally, that public health interventions limiting liberty require extremely careful justification based on those five conditions: effectiveness, proportionality, necessity, least infringement, and public justification.
So here's a final thought. Building on that tension between someone like Daniels, arguing for a right based on opportunity, and Buchanan, arguing for a duty based on enforced beneficence. It seems the whole debate really boils down to this fundamental conflict. Individual liberty, especially the liberty to keep and use your own wealth, versus the strong societal pull towards helping others, towards beneficence. Our society allows for huge differences in wealth. Is the resulting inequality in healthcare access just an unfortunate side effect of that liberty? Or is it fundamentally unfair in a way that morally requires us to intervene, even coercively? That's the line, isn't it? The incredibly difficult line we, as a society, have to keep trying to draw. Thank you for joining us on the deep dive. We really hope this framework helps you think through this vital, ongoing ethical challenge.